We get support from Audible. We've all got busy schedules. And I'm sure sometimes you feel like, with all the things you have to do, it's hard to find time for the stuff you love to do, like reading. That's why Audible is so great. Audible offers an incredible selection of audiobooks across every genre, from bestsellers and new releases to celebrity memoirs, mysteries and thrillers, motivation, wellness, business, and more. Plus, as an Audible member, you can choose one title a month to keep from their entire catalog, including the latest bestsellers and new releases. And also, I have to say, I love how the Audible app makes it easy to listen anytime, anywhere. When you're traveling, working out, walking, doing chores, wherever your day takes you. Cleaning the bathroom has really never been more fun. Let Audible help you discover new ways to laugh, be inspired, or be entertained. New members can try it free for 30 days. Visit audible.com/listening or text listening to 500-500. That's audible.com/listening or text listening to 500-500 to try Audible free for 30 days. Audible.com/listening.
My favorite thing about working in healthcare is the people. This industry brings together brilliant, highly motivated individuals who are driven by the opportunity to make a difference. My name is Hallie Tecco, and this is The Heart of Healthcare, a podcast where I'll be introducing you to the people on the ground moving the needle in public health and medicine. Even if you haven't caught COVID yet, it certainly has upended your life in some way. Postponed weddings, lonely birthdays, closed schools, losing loved ones. In 2021, with the introduction of not one, but 3 vaccines, we could see what we thought was the light at the end of the tunnel. But now, as Omicron case counts reach exponential new highs and hospitals run out of beds and have staffing issues, it feels like this will never end. It feels like this pandemic may just be our new normal. Today, I have the honor of talking to and asking this question to Dr. Bob Wachter, who is the chair of the UCSF Department of Medicine. For many of us, Dr. Wachter has been a source of frontline information on the pandemic since the beginning, with his regular Twitter updates that are full of data and insights on the state of COVID-19. Dr. Wachter has been named as the most influential physician executive in the U.S., and his book, The Digital Doctor, was a New York Times Science bestseller. Dr. Wachter received his medical degree from the University of Pennsylvania, completed his residency at UCSF, was a Robert Wood Johnson Foundation clinical scholar at Stanford, and studied patient safety as a Fulbright scholar. All right, Dr. Wachter, thank you for being here.
It is a great pleasure. Thanks for having me.
It has been a doozy of a few weeks since the holidays for all of us. Did you ever think we would still be dealing with this pandemic 2 years later?
I had a chance to guest host the Andy Slavitt's podcast In the Bubble till it was January through May last year. And when Andy came back, I asked him, what's the podcast going to become since COVID is ending? So that's what I thought in May 2021. So no, I did not think we would still find ourselves here.
Yeah, I don't think many of us have. So even though people are calling Omicron the mild COVID, hospitals are filling up. Talk to us about how even this mild strain of COVID can and has completely upended our healthcare system.
Well, first of all, it's milder. I don't love calling it mild because it's milder than a virus that has killed 840,000 Americans. So it would have to be a lot milder for it to be inconsequential. It's still a pretty big deal. And there's a math equation that isn't all that hard to understand, which is it can be half as severe, but if it's 5 or 10 times more infectious and more prevalent, that still lands you in a bad place. And that's what was predicted since we figured out that it was milder, but was much more infectious and partly evaded your immune system. And those predictions have come true. Actually, they've come true more than I expected in terms of the prevalence. In San Francisco, where I live, 6 weeks ago, we were having 50 cases a day. And now we have 1,500. And those are the ones that are being reported. All the ones that are being diagnosed through rapid tests are not being reported. So massively more infectious, massively more prevalent. And even though it's probably 50 to 70% less likely to land you in the hospital, that's still a ton of hospitalized patients. And now, on top of it, something we haven't had before, which is a huge number of healthcare workers that are out because they're sick. So,
Yeah.
combination of more patients in hospitals, some of them quite ill, all of them, not all, and a lot of healthcare workers who can't work is a bad scene. We're muddling through in San Francisco, in part because our vaccine rate is so high that we're not getting hammered the way they are in other parts of the country. But when I talk to colleagues in New York or Boston or Miami or Houston, it is really pretty dire.
Yeah. So what happens when hospitals are forced to start rationing care because there are no more beds or ventilators? How
Yeah.
will they decide how to do that? And then is there a case where they would ever give preference to those who are vaccinated?
No, I
No.
can't imagine that happening.
Mm,
The rationing, I think, is less because of the beds now, and really more because of the people.
mm,
Do we have enough people to staff the ICU or the ER? It's a chronic struggle in American medicine. I think a really interesting question in American medicine: do you give preference to people who have been acting, quote, well, and with a scarce resource? Do you limit it for people that contributed to the need for it? And so we have long confronted that in terms of treatments for people with lung cancer. Do you do it differently for people who smoked or didn't, for treating cirrhosis of the liver with alcohol, treating diabetes for people who are obese? And and in general, the consensus has been our job is to deliver the best care we can to the people that need it the most. And if your need for it came partly from something you did or didn't do, that shouldn't go into it. Even when there is a truly, truly scarce resource where we have to make those decisions. And the example I'm thinking about is liver transplantation for people for whom their risk factor was alcohol use. They often get triaged out. They often will not be eligible for a liver transplant. But the rationale is not that they did it. The rationale is their ability to keep themselves safe and stay on the medications and all those things that really are predictors of how they're going to do. Is the reason why, at least in some transplant programs, alcoholics won't go to the front of the line. So yeah, I could see people getting charged more in their health insurance premiums because it's the same as smoking or the same as not wearing a seatbelt, that they've put themselves at higher risk, and that's going to lead
mhm.
to greater costs. But I can't see that there will be rationing at the point of care, that this person is allowed to die because of a decision that they made. There's no tradition of that in American healthcare.
Yeah. But hospitals are already having to ration the antiviral drugs from Pfizer and Merck that are available, but available in limited quantities. How is that currently being done?
Yeah, I think it highlights the issue you just brought up, Hallie. I think it's a tough call, but at least so far, the decision making. Let's take the Pfizer drug, which is really the real game changer of all of the drugs, and it's not so much in the hospital world. These are pills that we can give people as their outpatients who are at high risk of a bad outcome. And if you only have so many, and that is the situation now, there's a limited supply. It will grow over the course of the year, but for now, it's quite a limited supply. The decisions that every hospital I know of has made is to prioritize people by virtue of their risk of a bad outcome and the benefit of those pills if they take them. So what the pills have shown to do is decrease the probability that someone with COVID will get super sick and end up in the hospital and end up in the ICU and die by about 90%. So that's pretty
Mm,
are.
yeah.
But who is first in line to get them? I think first in line at our place is immunocompromised patients
Hmm.
who are at high risk and for whom the vaccines often didn't take. But the fact that if you have an elderly person who's at high risk by virtue of their age or their comorbidities, and they're unvaccinated, that puts them at a substantially higher risk of a bad outcome and hospitalization and death than it would be for me, who's gotten 3 shots. So that person will get prioritized over me. Will that piss me off? Yes, as a human
Yeah.
being. Is that the wrong call? Epidemiologically, no, it's not. That their chances of getting sick are far higher than mine are. And so it's actually a reasonable call if the idea is to save as many lives as possible, although you can see why it would be controversial.
Sure. Yeah. I mean, I'm hearing stories from physicians who have to have to face patients who chose to be unvaccinated and then are asking for treatments that are not proven and are in, position of, I've been telling you to get vaccinated and now you're sick and you are asking for something experimental, but claim that the vaccine was experimental. I can't imagine how hard it is to work in and how demoralizing it is to work in the hospital setting right now when you're doing everything you can to save lives, but patients who have tools to save their own lives aren't necessarily doing what they can do.
Yeah, I mean, we're sort of trained to put that part of our brain aside a little bit and not do our best to take care of people as well as we can.
Hmm.
And but we're human beings, and it would not be human, I think, to not be pissed at a patient who is coming in, and particularly one who now wants an experimental and unproven therapy, which is just
Yeah.
sort of just insane. I mean, that there are parts of this that are just sort of so ridiculous and foolish that you almost have to laugh if it wasn't so serious. But
Yeah.
the fact that they have made a decision not to take a breathtakingly effective and extraordinarily safe vaccine, which could have prevented them from coming in the hospital, and now here you are up to your neck in COVID patients and other patients who can't get into the ER. They're sitting in the waiting room because the hospital is packed, and you're coming in every day and you're putting your own self at risk to get sick through an infection that you may get from someone who's made a decision to put themselves at risk. So
Yeah.
what's a little different about COVID than a lot of the other things that we deal with all the time in healthcare is your decision to drive fast, not wear a seatbelt, smoke, drink, is that's a really bad decision on your part, but the cost will be to you, and it's sort of all within that person and their decision making. Here, your decisions influence others, put others at risk, put the entire community at risk.
Yeah.
Arguably, are the reason that we find ourselves still in this pickle. So I think it
Yeah.
wouldn't be human to not be a little bit angry about it and
Hmm.
frustrated about it and disappointed in it. But yet, I think it is part of our training to try to the degree possible to put that aside and do the best we can to take care of them.
Is there a class on that you took in med school?
Boy, med school is so many thousands of years ago. I don't remember. Yeah, I mean, it's interesting. I probably can tell you more from watching my daughter as a fourth year med student at UCSF.
Mm.
And part of the socialization of physicians really is taking you from the world of a layperson to the world of a physician. A lot of that is a knowledge base. You're learning to be an expert in a domain, as the same as you're learning if you're in business school or law school or any other professional school. But part of it really is a mindset and kind of a professional temperament. And and
Mm.
whether it's a single class or whether it's sort of just the gestalt of what you see around you when you start taking care of patients, it's very much part of the culture of medicine. And it's part of kind of a broader thing. I've been thinking a lot about this recently because my son just got COVID, and I've been kind of dealing with that. It's part of a broader thing that happens to lay people as they become this thing we call physicians, which is learning to sort of take the emotional part of dealing with some really often tragic situations, and also park it in a deeper part of your brain, which if you take that admonition too far, you of course become unfeeling and robotic and not a very good doctor. But if you don't take it far enough, you can't practice medicine. I mean, if
Hmm.
every person I took care of who died, threw me for a loop for a week, I couldn't do my job. And so part of it is sort of learning how to manage your emotions and all those things so you can suit back up and go and take care of people and do the best you can. And it is definitely part of the journey on the way to being a physician.
Yeah. Are you worried about the mental health of your colleagues after the last 2 years?
Yes, I think there's a huge amount of burnout. I think that people are a lot of it is what they've seen in the hospital, and particularly in cities that have been harder hit than San Francisco. It's been traumatic. It's sort of a battlefield thing. Part of it is the politicization of COVID and the fact that there's just more tension in the air. I mean, I have friends of mine who became litigators. They went into a field where they knew they were going to have arguments with people all the time. That's the business, and for them, they liked it. In medicine, you didn't go into it for that reason. You generally feel like I'm going to be on the same page with my patients, and we're trying for the same goal. We're trying to make them better or keep them healthy. And the fact that for many people, and again, less in the Bay Area than colleagues in other parts of the country, there's so many relationships that now have become tense and confrontational, which is, of course, just a metaphor for our entire society. I think that's difficult. And then for a lot of people, it's not just your professional life taking care of COVID, but then you come home and you deal with all the traumas that everybody's dealing with, dealing with the kids and dealing with your aging parents but there's a little bit of a special piece of this that you've been spending all day taking care of COVID. You come home and you worry very much, did I catch it at work? And am I going to give it to someone I love? So that's a lot of trauma to people, but I don't know that it's that much worse than what a lot of other people are going through. It's obviously an incredibly hard time.
So switching gears, what do you think our lives will be like this summer? Please tell me some good news.
The summer is about as far out as I'm comfortable predicting. I'm glad you didn't ask for the fall and winter. And I'm quite comfortable with the spring, and then
Great.
my level of comfort falls off the further life goes.
Okay, well, tell me spring then summer.
You have to recognize, all of us who've been in the prediction business for the last couple of years, and unfortunately, when I make predictions, it's often on YouTube for people to watch and see that I got it wrong. There have just been so many predictions that have turned out to be wrong, not because they weren't thoughtful and sensible at the time. It's just curveball after curveball after curveball, and it has made us circumspect about predictions, probably to the point of being overly circumspect, because at some point there won't be a new curveball and those predictions will come true. Here's what I think is likely to happen for the next few months. That it's amazing how fast the science has moved. A month ago, we really didn't understand Omicron and how infectious it was, and immune evasion and severity and all those things. We now understand those things really quite well. So the other thing we understand is this pattern, which when we first saw it in South Africa, where cases went up like a skyrocketed and then came down just as quickly, really within the space of 6 weeks or 8 weeks. You kind of wonder, is that just an N of one? And South Africa has some distinct aspects to it. Will that play out elsewhere? So now we understand not only the biology and physics and math of Omicron, but we have seen that pattern from South Africa play out now in England and in Ireland. And we've seen cases that were skyrocketing in New York, Boston, Washington, D.C., and now even in the Bay Area, beginning to either plateau or start to come down. So I think we can be pretty confident that that's the South Africa pattern will be what we see. This is fast up, pretty brutal, and hospitals full, bad stuff happening, a lot of people getting sick, a lot of people dying, ton of people getting COVID, and then fast down. And it takes as long to come down as it took to come up. So, we're probably at about the peak in the United States now, maybe a week away. And so I think you could say by mid-February, likelier than not, we will be at a fairly low level of cases. And why that happens, why it comes down so fast, nobody fully understands. Clearly, part of it is that you've now given a higher level of immunity to the people who got breakthrough infections, and maybe any immunity to many of the people who have been unvaccinated. So in mid-February, I think we are likely to find ourselves in a place where pretty much 100% of the population has some immunity from some combination of vaccines and infection. You have a virus that has not gone away, but is at a relatively low prevalence. And that's a huge deal. Right now, if I walk into the Starbucks in my neighborhood in San Francisco, it's about a 1 in 10 chance that somebody in the Starbucks has COVID and feels fine.
Yeah.
If the prevalence comes down to where it was 6 weeks ago, that's more like 1 in 500. So it's just a math problem. You're just far less likely to be exposed to it. So low level prevalence, low level of virus in the community, at a time where the virus itself is probably about 50-60% milder on average. So if I do get infected and I have some immunity, which even the no vaccine people will now have from their infections, I'm at least somewhat to very protected against getting very sick. On top of that, particularly the Pfizer medicine will be increasingly available, still not available for everybody, but available enough that high-risk people, who would be the ones that might land in the hospital, I think will have access to that. When you add all that up, you end up in a pretty good place. And I think people are somewhat resistant to hearing that because they've heard it before, or they think you'll jinx it, or they think everybody's going to let their guard down, or any of that stuff. I am being super careful now. I do not at all buy the idea that everybody's going to get Omicron, might as well just have a party. I think that's stupid. I'm being super careful, in part because I think I only have to be careful, really careful, for the next 3 or 4 weeks. I think we end up in a good place. Then the question is, how long does that last? And anybody who tells you they're sure about what the summer or the fall looks like is making it up, because it's completely predicated on two things that we do not know the answer to. One is, what is the probability that a new variant comes and is nastier than Omicron, either in immune evasion or infectiousness? And anybody who says that can't be, look how good Omicron is at its job, just go ask them, did they predict Omicron? The answer is no, so you can't believe them. The answer is, there is some, I think small, but non-zero probability that we get something even worse. That changes the ballgame. The second thing that changes the ballgame is part of the reason we're in a good place in February and March is that all of these people, particularly the non-vaccinated people, which shockingly is a third of our citizens, have gotten some immunity from their infection. How good that immunity is and how long that lasts is completely unknown, because we won't know it until enough time has passed to see. And so those are the two variables that I think make it incredibly hard to predict whether we'll still be good next fall, next winter, but I'm quite confident that spring will be fine.
Yeah. I'm wondering if anyone is starting some sort of COVID vacation insurance based on these predictions.
Well, I just bought tickets to a friend's 65th birthday party in early-ish February, and it cost me $200 to get a fully refundable ticket, and I spent the $200.
Okay,
So that's kind of where I am. Assuming it'll be okay, but hedging my bet a little bit.
Yeah, I'm getting for a spring trip to Disney. It's been too long for my 4-year-old, so need to do something special for him.
Yeah.
So you mentioned people not thinking it's smart for people to just try to get it over with. Did you hear about the Australian woman who wanted to get Omicron before her wedding, and so she went to the bars and started drinking people's drinks and hugging strangers so that she would get it?
I didn't, but it's a big world and there are a lot of crazy people.
Yeah. So what would you say to people, maybe not that extreme, but what would you say to people who have just given up? They're just tired. They're lonely, they're bored, they're angry, and they see that their friends are getting it. And it's, for their friends, it's a cold. What would you say to them?
First of all, I understand. I mean, we're all tired and unhappy and grumpy, and all of these curveballs have jerked us around. So the sentiment is normal. It's not the right thing to do, and part of it is that what I just said. I mean, the best prediction is that you just have to muddle through for another 3 or 4 weeks, and you're going to be in a far better place. A lot of people have. I think this idea that it is mild is a mistake, and to some extent it's right, and to some extent it's wrong. What they're taking is they're conflating. When you see statistics on COVID and on Omicron, you often see them parsed as in severe or not severe, and that's what we use for clinical trials. You did a drug work. Well, severe means you were sick enough to go to the hospital. I mean, that's really sick. That means you were desperately short of breath and you needed oxygen, and we thought you were at very high risk of a bad outcome, including dying. That's severe. Not severe is everything from a cold, you had sniffles and sneeze for a couple of days, to what my son is finishing up now, which is about 5 days of feeling like he was run over by a bus, to some people that are really laid up for weeks, to probably about 5% of people that have long COVID, meaning 2 to 3 months out, they still don't feel right. And whether not feel right is their brain's not working right, or they're still short of breath, or they're still truly fatigued. And for those people, it's very real. So that is, and you're not risking any of those things if you get your immunity through your vaccine. So I think it just doesn't make any sense to go ahead and get it and risk the possibility it'll be a pretty severe case, risk the possibility that you'll infect somebody else while you have it, as opposed to, some of those people have not gotten their boosters. I mean, just get the darn booster. I mean, that's what you should do. If you want immunity, the best way to get it is with a vaccine as opposed to an infection. And again, I think if you're in the, all right, I got to be careful, it really is probably for another 3 to 4 weeks, and then we'll be on the other side of this thing.
After the break, Dr. Wachter will be answering questions from folks on Twitter.
Has your chronic illness made it difficult to continue working in the traditional way? Want to learn how to find and create flexible remote work that both accommodates your chronic illness and generates an income? Join the Patients Getting Paid membership, a community of chronicpreneurs where people just like you find workshops and trainings, weekly updated condition-specific gigs, twice monthly coaching calls, co-workings, accountability, and the kindest community to support you on your path to make money while working from anywhere and taking good care of yourself. Learn more or join us at patientsgettingpaid.com.
We all struggle with feeling like there's not enough time in the day to be productive personally or professionally. We all struggle to make our time matter. It's time to take control. It's time to start investing in the corporation of you. At Athena, they've helped over 700 ambitious professionals achieve more by connecting them with best-in-class, globally remote executive assistants. Athena executive assistants go beyond basic administration tasks. They help you make time matter through the art of delegation. They believe delegation is the superpower of all highly successful people, and your personal EA will help you get there. Your EA is a one-on-one long-term partner to help you achieve your personal and professional goals. Take back your time. Join the waitlist at athenago.com. That's athenago.com.
So let's move on to some questions from people on Twitter. Dan McQueen wants to know, how do we encourage the general population that the CDC has their best health interests in mind when their recent adjustments to guidance recommendations appear to be motivated by economics over science?
Yeah, it's tricky. The CDC, is a world-class organization with very good people trying to get it right. I don't have any doubt that their motivations are to preserve the public health to the degree possible. But preserving the public health also includes having the economy that works and making sure that we can staff our hospitals and making sure that people can travel if they want to. So I don't think it's as clean as, public health versus the economy. The decision that he's referring to probably is the 5-day isolation decision. And I think that was not so much about the economy. I think it was probably about the shortage of testing. I think that they looked and said, if we say you can be released from isolation, but we're going to require that you have 2 negative tests, and then you go to your local pharmacy and can't find a test, then first of all, you're pretty unhappy. Second of all, you're kind of stuck. Like, what do I do now? And so I think the policy problem there was the absence of tests, that we did not invest in making tests ubiquitous as they are in most of Europe. And then they tried to fudge it, and they said that the tests aren't all that reliable, which I think is just not true. I think they actually serve that purpose quite well, that they will tell you at the end of 5 days, are you still infectious or not? So I just went through this with my son. On day 5, he was feeling better. According to the CDC guidance, he was okay to go back to work as long as he wore a good mask. If he'd gone back to work, the chances he was going to infect someone was very low, as long as he was wearing an N95 or the equivalent, but it was not zero. And I've managed to find a test, which wasn't easy, and he tested positive. And he's still testing positive on day 8. So I think the right call is for him to stay out of human contact until his test turns negative. But acknowledging it's a hard decision. I don't think it was the economy versus public health. I think it was more the economy keeping society going, recognizing the risk of him infecting people is low-ish, recognizing there are a ton of people walking around who have COVID and don't know it, and they're probably a bigger threat than these people who are on day 6, and recognizing there aren't enough tests around. I think they tried to pull all that together and coming up with a decision. I sort of just think they got it wrong. And the right call is to test people and to get more tests out there so you can test your way out of isolation.
Yep. Okay, so Carrie 8 wants to know, how is UCSF and other top medical institutions researching and treating long-haul COVID? And what are you seeing as people's prognosis?
Yeah, it's a great question. There's a huge clinical trial that's been started by the NIH. Some of our top virology and immunology researchers, Steve Deeks and others, are focused very much on long COVID. We've got a long COVID clinic at UCSF where we take care of patients, but also study them to understand what's going on with them. I have to say, like a lot of persistent symptoms in medicine, including chronic fatigue syndrome, we just don't understand it very well. It's clearly real. It's a hard thing to study because if you ask the general population, do you have fatigue, brain fog? A lot of people say yes. So you have to really have a good control group to be sure that the prevalence is substantially higher in people who've had COVID. And it clearly is. There are some people that have symptoms that go on for many months. My reading of the literature is it's still pretty messy. I don't think we have a deep understanding yet of how many people is it that the virus is continuing to kind of rumble inside them and causing its own mischief. How many of them is it their immune system reacting to the virus and then continuing to course through your body and cause its own problems? It's not very well known what is going on with people with long COVID. What is the prevalence? I think the best estimate that I would take from the literature, and it's all over the place, but the best estimate I would have, and it's what goes into my decision making and one of the reasons I really trying hard not to get COVID, is that I probably, being a fully vaccinated person, probably have about a 1 in 20 chance of having symptoms that will go on more than 2 months. And that's enough to be yet another thing that makes me want to try to avoid getting it if I can, as long as it's particularly at a time where it's so prevalent in the community.
Yeah.
And what the treatment is, I think at this point, there are a lot of things that are being tried, including vaccination. And we don't know the answer. So the best treatment is to stay vaccinated and try to be careful enough not to get it. But that's the number I use, is probably 5% in fully vaccinated people. Vaccines look like they lower the risk somewhat, so maybe 10% risk in unvaccinated people who get COVID.
All right. Trey Lauderdale wants to know when you think kids under 5 can get vaxxed. Pleading face, pleading face, pleading face.
Yeah, we don't know. The clinical trials are ongoing. The original trial, where they make their best guess as to what the right dose is and what the right spacing of the dose is, didn't yield the immunologic effects that you want to see that correlate with protection. So they had to go back to the drawing board and expand the clinical trial and change the dose regimen a little bit. I think the best guess is it'll be another 3 or 4 months. That's what I've heard. It's sort of March, April. And so, the good news about the little kids is the probability of a severe case is extraordinarily low, but we are seeing more cases in them, in part because they are one of the populations that still is unvaccinated, and obviously because they can't be. So, and I don't have little kids anymore, and I have tremendous sympathy. I sort of almost can't imagine what it's like trying to keep them protected during this time. And you just have to do the best you can do, which is doing your best to surround them with people that do not have COVID and have done everything they can to not have COVID.
Yeah. Ryan Pachadsaram wants to know, what is the likelihood that we will need booster shots every year? Does this become like the flu?
Yeah, I think the likelihood is high that we will need periodic booster shots, and because for many other infections like this, and flu is probably the best analogy, you do, in part because immunity wanes, and in part because there are variants that do enough shape shifting that the vaccine from last year doesn't work quite as well as it needs to. The good news about that is there's no great reason why you couldn't package it together with the flu vaccine. So maybe we just get one shot a year and one and done for both illnesses. I think implied in the question is, when does it also become like the flu in terms of the risk? And I would say once this surge is passed and once we're down to a relatively low prevalence, then the risk of getting very sick and the risk of dying for a fully vaccinated, by that I mean 3 shots at this point, boosted person, is actually quite similar to the flu. Now, the flu's not nothing. I mean, the flu kills 30 to 50,000 Americans a year, but not 400,000 Americans a year. So, but once you get to the point of now a milder virus than we've had before, the substantial protection against getting very sick that's afforded you by 3 shots of vaccine, and then you layer on top of it, particularly the Pfizer drug becoming more available to take people at very high risk and lower their probability of getting very sick and dying by 90%. Then you have a situation, people are resistant to this because, like the flu, became politicized like everything else. And, a year ago when people said that, it was a lie. It absolutely was not like the flu. To kill 400,000 people a year is very different than the flu. It was far, far worse than the flu. But at some point, we have to accept that, in fact, it is. And I think we're getting close to that. And, when I talk about next month being a time where I and we may go back to acting not quite 2019. I'll still wear a mask on airplanes for a while, for example, but not that far off. It is because that's a pragmatic decision that the risk has fallen to the point that it is not all that different
Sure.
than the risk from the flu.
And some communities have been doing that for decades. In Asia, particularly, you see people way before COVID wearing masks.
Yeah, I remember the first time I went to Japan, and I was so shocked seeing half the people on the street and almost most of the people on subways wearing masks. And yeah, it'll be fascinating to see how we come out of this, that in Asia, they became kind of mask wearing cultures and it became normalized. It wasn't a big deal. I think that will probably, like everything else, parse itself by where you are in the country. So I think if you're on a BART train in San Francisco, I think you'll probably see a lot of people wearing a mask. And if you're on a train in the middle of the country or in the South, you probably won't see many people wearing masks.
So last question, Dr. Carol W. wants to know, how can we help guidelines around COVID precautions, quarantine, testing from the government or companies be agile and respond quickly to future variants?
Yeah, it's, embedded in the question is a part of the tension here, because you don't want them to be too agile, because that gives people the sense that you're jerking them around and you just told me last month that I can wear a cloth mask, but now you say that's no good. And, you told me that I need to stay in isolation for 10 days. You now say 5, but now you're saying maybe I should test, but maybe I shouldn't. So doing public communication in an age of a threat like this that changes its nature so quickly, and thereby the science changes incredibly quickly. I'm on Twitter, every hour there's something new that I didn't, that what I thought yesterday isn't quite right. So I think you have to be careful there not to change the guidance as too quickly, and to be thoughtful about, is this going to be guidance that will have staying power? But then, of course, condition it. When I said I'm ready to start traveling and living life more normally in May, and I said it again in November, that is what I thought, given what I knew at the time. And a month later, I was acting differently because the risk had changed. And to say to people it can't ever change, like saying to people you don't have to ever worry about a hurricane. Well, we don't worry about hurricanes until you look up in the weather report and it says there's a hurricane heading toward your house. Well, you're going to worry about it then. So we have to be nimble enough to change when the circumstances really dictate it. But we want to be a little bit careful about not changing so often that people just give up on, sort of stop paying attention. And there's a risk of that as well.
Yeah. Being a public health communicator in these days must be a very challenging job.
Yeah, in a way, although, it's one thing for me to put out my take of what's going on Twitter, or do it in other conferences that I run. I have real sympathy for people doing it in the government. In some ways, I'm being an armchair quarterback, and then the stakes are higher. If I get it wrong, maybe a few people listen to me and they stop following me on Twitter. If they get it wrong, they've, influenced the spending of billions of dollars and the behavior of millions and millions of people. It's a really tough job. And,
It really is.
I have a lot of sympathy for them, and feels different than it did 2 years ago. These are very good people. There's politics because there's politics, but it's not a terribly politicized environment. They're trying to get it right. And periodically, though, I think they do get it wrong.
Is there anything else you want our listeners to know before we wrap up?
Just take heart, and be kind to each other. We've all been through a really traumatic period, and it's been interesting, for example, on Twitter, where The other day, as I've been chronicling my son's illness, and I mainly did it not because it was unusual, because it was so incredibly common. I just thought it might be interesting for people to see how I, as quote an expert, was processing all of it. And I said, he was still testing positive on day 7. And I said, I love him to pieces, but I wouldn't want him to breathe on me. I found this amusing, fine. People said, oh, you are a terrible parent. There would be no circumstance under which I would not want my child to be able to hug me. Well, first of all, he's 28. And second of all, I'd be happy to hug him if he was wearing an N95 and I was too. But I think everybody's gotten so edgy and a little nasty that I think we've got to really be a little bit more patient and kind if we can muster it.
Yeah, we all need to take a few breaths sometimes.
Yeah.
Well, Dr. Wachter, thank you so much for the work that you're continuing to do and for sharing your insights with us today.
It was a pleasure. Thanks so much for having me.
If you want to follow Dr. Wachter on Twitter, he's at Bob_Wachter. That's spelled Wachter. If you want to follow me and provide ideas for future shows, I'm at Hallie Tecco, HALLETECCO. This is the Heart of Healthcare podcast. Thank you for listening.
Thanks for listening to this episode of The Heart of Healthcare. If you like the show, be sure to subscribe, leave a review on Apple Podcasts, follow us on social, and tell all your friends to listen. The Heart of Healthcare is a product of OffScrip Health. We are a healthcare engagement company built for patients and caregivers by patients and caregivers. Our executive producers are Matthew Zachary and Andrew McDowell. Our senior producer is Brianna Seeley. Our intern is Antonella Sterniolo. Our host is Hallie Tecco. It is recorded, mixed, and edited by Brianna Seeley. For advertising and media inquiries, email media@offscrip.com. That's media@offscrip.com. For more information, visit offscrip.com.